Hello everybody, I am Shin Ushiro of Kyushu University Hospital, Japan Council for Quality and Healthcare, and ISQA under the Ministry of Health, Japan. I'm going to talk about briefly on quality assurance system in long-term care in Japan. The title is Improving Safety and Quality in Nursing Care Facility Through the Knowledge on New ICT, which is telemedicine in medical institutions. So let's get started. Well, in the first place, I am showing the trajectory of population rate over the age of 65 of 2021. Japan is standing at here with the population rate over the age of 65 is nearly 30%, which means we are in the middle of super-aged society. Well, this slide is to display a chronicle of the development of insurance for long-term care. In 1960s, we promoted to build care forms for the elderly, and home helper system was institutionalized. In 1970s, healthcare for the elderly was completely free. But in 1980s, as the growth of the aged population, we adopted co-payments for the elderly health care. So this is a moment of the end of free healthcare for the elderly. And we also launched a 10-year strategy for the promotion of health and welfare for the elderly, and we promoted installment of facilities and in-home welfare services. In 1990s, the 10-year strategy was extended, and we also enacted the Long-Term Care Insurance Act. And finally, in the year of 2000, we enforced the long-term care insurance system with aged population as many as 17.3%. But nowadays, the population grew into nearly 30%, as stated in the previous slide. So at this point, I'd like to stress that long-term care was a family system long time ago in my country. It was delivered by family, relatives, etc. But quality fluctuated among families. But over the last 10 years, long-term care was increasingly regarded as social system backed by national long-term care insurance. So it should be delivered by designated facility or by professionals, and quality needs to be controlled. So this slide shows the current system of long-term care services. And I would like to emphasize that grading system works in our system. The elderly goes to local government, and the local government reviews them, and also physicians reviews them, and the local government gives certification of care levels or support levels. If you are assigned to care levels 1 to 5, you will get facility service, in-home services, community-based services with the care plan. And if you are less fragile, you will be given a support levels 1 to 2, and you still get preventive long-term care services, community-based services for preventive long-term care, focusing on prevention. And if you are out of those levels, you still get some services. As such, the grading system is working effectively in our system. The Japanese government has promoted a community-based integrated care system over the last 10 years, and please look at residents sitting here, and we provide hospital care, daily care by clinic, dental clinic, and pharmacies. We provide long-term care, and we provide a community-based daily life aid or long-term care prevention services. So what is important is that those services needs to be delivered to the elderly in seamless manner. So at this point, I'd like to switch my subject to telemedicine. In the year 2018, the Japanese government Ministry of Health issued guidance on telemedicine with the help of professional societies. This slide and The next slide shows the table of contents, which is really details. So I would say that our Japanese government has been very cautious about introducing telemedicine into the front line of medicine. So Japan Medical Association, dubbed as the JMA, which is politically influential in Japanese medical society, has long stated that telemedicine is a complementary medicine applied in such cases of restricted access to medicine that could hardly be resolved as geographical restriction, scarcity of medical facilities, restricted access to medical facilities like home care, care for women immediately after birth, occasional request of verbal health consultation, etc. In addition, JMA has a different point of view, which is financial prospection. And what you see here is the clinical procedures. JMA states that in-person consultation covers all of them, but while telemedicine covers part of them. So they say that bills issued to the public healthcare insurance shouldn't be the same between in-person consultation and telemedicine due to difference in coverage. I mean, the price should be different. The no coverage over costs for building and operating community network is challenge to address. So, in other words, they say that they need some more money to build a community network when they conduct telemedicine. So residents get sick at home or in long-term care facilities. Medicine is provided to them in need in such different forms as number one, consultation at hospital and clinic. Number two, home care facility visit consultation. And number three, telemedicine. All 1 to 3 are available in the coverage of the National Healthcare Insurance System. However, the care has long been deviated to face-to-face manner, weighing on inspection, palpation, percussion, oscillation, etc. Telemedicine has been principally allowed in such specific and limited settings as rural areas, etc. Payment of national healthcare insurance to telemedicine has been more strictly restricted than in-person consultation, such as outpatient consultation and home visit consultation, because of the conventional idea that the telemedicine is less effective. However, the COVID-19 pandemic brought dramatical change to the situation of telemedicine. In March 2020, then Prime Minister Abe urged the promotion of telemedicine by deregulation. In April, the panel in Prime Minister's office followed his statement. Nevertheless, we observed the strong opposition by experts in the serial meetings on telemedicine in the Ministry of Health. They stated that it is highly risky to see patients with no history of consultation and prescribe medicine. It is impossible to make correct diagnosis to patients with no history of consultation by procedure without lab test. But finally, despite the strong oppositions, telemedicine was approved. For first consultation on patient, I mean no history of consultation in the past, on condition of tentative trial during urgent situation. So JMA claims that after pandemic, the measure should be reviewed. So in the coming couple of slides, I'd like to describe how much you are rewarded when you conduct consultation for patients from National Healthcare Insurance System before COVID-19 and during COVID-19. If you conduct in-person consultation, you will be rewarded for the first visit, initial visit, with a price tag of 288 points. Please note that 1 point corresponds to 10 Japanese yen. 288 points nearly equals to 26 or 27 US dollar. And if you continue consultation, you will be rewarded for subsequent visit, 73 points plus regular maintenance fee from 87 to 1,681. That could be huge. However, if you look at the price list of telemedicine, for initial visit, you will obtain 0. and you will get 71 for subsequent visit, but you only get regular maintenance fee as much as 100, far less than that of in-person consultation. And telephone inquiry fee is available, but it doesn't come with regular maintenance fee, 0. And there is another restriction on frequency of telemedicine. So as seen here, the telemedicine has been less promoted in Japanese healthcare insurance system. So before COVID-19, telemedicine was hardly profitable. But at emergence of COVID-19 in 2020, patients under in-person care hardly visited clinics and hospitals. Demand of telemedicine, mostly through telephone conversation, rapidly grew in clinics and hospitals. So during COVID-19 and even as of today, under the leadership by the Prime Minister, tentative measures were taken to make telemedicine profitable. I hope that new ICT will bring dramatical change to the situation of telemedicine in my country. So this is the revised price list of telemedicine during COVID-19. The consultation fee for the initial visit, first visit, has got a price tag as much as 214. And the telephone inquiry fee, telephone conversation, was also given regular maintenance fee as much as 147. Those two are very, very big. And another restriction of frequency of telemedicine was halted. Well, last but not the least, I'd like to talk about quality assurance in community-based integrated care system, particularly in long-term care facilities. Well, here I have listed quality assurance system of long-term care, mostly provided by the local government. We have, for instance, regulation system by licensing operator and certifying physical structure of facilities. And these systems are reviewed from three different viewpoints, such as structure, process, outcomes stated by famous Dr. Donabedian. We have minimum regulation on minimum requirements on the number of caregivers, equipment, etc. And we also have minimum requirements on delivery of care, such as service delivery with documented consent by resident and family, tailored care planning requirement, etc. And to come to think of regular inspection, inspection is carried out when requirements are breached, and it may issue a disciplinary directives on document basis, and it may take disciplinary action on comprehensive care management. And when it comes to compulsory disclosure on operational data on long-term care facilities, data on equipment, number of caregivers, resident, and status of quality improvements such as production and utilization of resident life record, cooperative and complementary system with other relevant facilities are all disclosed on the web. And last but not least, we also have financial incentives through our insurance system. We have additional fee to specific services such as facility visit, rehabilitation or nursing, and other cooperative and complementary activities. And we even have incentives to outcome. We have additional fee on general acceleration of returning home or acceleration of returning home through medical care. So if the elderly comes back quickly home from the facility, you will be rewarded more from the insurance system. Well, despite the quality assurance system by the government and by the private sectors, we still face a lot of problem on quality in long-term care, particularly on safety. What you see here is the newspaper report, which states that a registered nurse was vindicated at the appeal court of criminal oversight in relation to residents' accidental suffocation. What happened in the event is that a resident died from asphyxia due to failed ingestion of donut after a meal. Maybe this donut is dessert of the meal. District Court sentenced the guilty of the nurse's care in 2020, but later on appeal court overturned it. Things like this still happening in my country on the quality of long-term care. Well, when it comes to quality assurance in hospitals, JQ, my organization, has conducted the hospital accreditation and the nationwide adverse event reporting and learning system of medical institutions and community pharmacies. This is to show the overview of our adverse event reporting and learning system. We get individual cases through web-based reporting system. And we have produced regular report and monthly alert database, and we also provide a training course. And this system has been operated by steering committee in the presence of patient representatives. And this system was really effective, and we thought this system could be applied to the setting of long-term care. Well, according to the National Patient Safety Policy, Japan has launched a reporting and learning system one by one. It covers medical institutions, pharmacies, and perinatal care and accidental death. One of the products of our reporting and learning system is monthly alert, composed of 2 pages, including a couple of cases which took place actually in my country. What happened in one of the cases that on admission, the physician entered a normal meal without checking the meal type specified on the patient referral document. The nurse didn't observe the patient to see how well he or she managed chewing and swallowing. So one day, patient was reported to be choking. The patient's data on the saturation of oxygen had dropped to 80%, which is very low. A large amount of cooked rice was suctioned. The meal type should have been 100% rice gruel and chopped food instead of normal meal. So we stress that the event like this could happen in long-term care facilities or even at home. So we thought our products could apply to the settings of long-term care facility. So years ago, JQ launched a study group on reporting and learning system of incident which takes place in long-term care facility and settings with the funding by the government. And as of now, reporting form is being developed. The form of medical institution and pharmacy were rigorously reviewed. They were very, very helpful. And the specific items for long-term care facility to report are added, such as degree of frailty, allotriophagy, which is the eating habit of things which we usually do not eat, and referred to medical facility by ambulance or walked in. Date of report to family, damage payment, report to authorities, i.e. local government or police. Those items are additionally included in the possible forms for the reporting and learning system of long-term care settings. So finally, I'd like to summarize my talk for takeaways for you. Number 1, as long-term care burden grew at home, Japan launched the insurance system for long-term care in the year of 2000. Residents under long-term care principally need to see physicians, as in-person care has been attached importance to. Telemedicine has been available but less refunded in national healthcare insurance. It has been limitedly seen in setting as remote care, etc. COVID-19 pandemic dramatically changed the situation. Telemedicine is allowed more payment during the pandemic. Payment after COVID-19 is still uncertain. regarding safety in long-term care facilities. They are vulnerable to accusation, lawsuit, etc. in Japan. In an attempt to enhance quality, safety, and transparency, JQ under the MOH is studying incident reporting and learning system of long-term care facility. So that's all I have today. Thank you very much for listening.